I want to thank you all for this wonderful honor today, so I'm going to share a story with you. Complex regional pain syndrome can lead to permanent disability, amputation, and even suicide. But for 150 years, it's been debated, what is it? How do we treat it? How do we describe it? So words fail me. Thankfully, Lisa Boivin of the Dean Nation is doing her PhD on the atrocities of colonialism, lack of autonomy, and lack of choice in healthcare. And she is changing healthcare with this story. So my teacher and friend Lisa is allowing me to use this method to teach you today. My story began as a second-year neurology resident being largely ignored on an all-male service in Toronto. There was a man in the intensive care unit with seizures, unconscious, doing this. And I saw his arm transform in front of me, becoming hot, swollen, stiff, and he grimaced in pain. I was completely ignored. So every time I was on call, I charted his findings. And on my last day, I ordered an X-ray bone scan, a detailed plan, and I abandoned him. Thankfully, Dr. Denise Richardson, physiatrist, saw him in rehab. She called me one day to say, "Paul, your patient is doing really well. We read all of your notes. You explained it very well. X-ray, bone scan were positive. We put him on prednisone, and he's made an excellent recovery." His wife is very happy. But I need to tell you, I see and hear your pain. You were ignored, but you did the right thing. So when I was in practice, this would never happen again, and this is one of my first patients. A man tripped, hyperextended his neck, paralyzed both arms from a disc herniation. He had an excellent course because of excellent neurosurgery, recovered his arms, and went home early. I then saw him one day in the hospital months later looking terrible. I said, "What's wrong?" He said, "My arm, it's on fire. It doesn't work. I can't make a fist. I can't lift it up. I'm on my way for an MRI." I rushed him over to the medical imaging and got a bone scan ordered. He had increased uptake in all the joints of his hand. I put him on prednisone and he sent me this wonderful gift. Within a week, he had almost full resolution and he was using it again. So that's CRPS. It's unexplained pain. You have some type of injury in one part of your body, and then the region beyond it gets this terrible pain disorder out of proportion to what it should be. Nobody really understands it. But you get swelling, you get skin changes, color changes, new hair growth, hot, cold, and it can't be explained by something else. If it's after a nerve injury, it's type 2. So I began to catalog my patients with these types of imaging. They joined me in the recovery. We told a story. And one after another, more and more therapists and surgeons began sending me their patients, and more were getting better. They wanted to show their faces. They wanted to be part of the story. They wanted to get well. And they knew patients were afraid to try a short course of prednisone. So why prednisone? The literature for CRPS is extremely poor. There's very few randomized control trials. There's no recommended treatment, and most of the patients present well after a year when the disease is mature and you can't change it. So with prednisone, however, there's some very good small studies that show it's actually disease modifying. And it works within a few days, you know it's working. You see the patient transform in front of you. So how can you not use it? So I put out my first paper with 4 visual descriptions of patients, and it was published. And people started calling me from across the country for help. It can happen to a teenager, simply an ankle sprain, and then they're on crutches and can't walk. And within 4 weeks to 2 months, they are running. Dr. Andrew Furlan, a good friend and full-time pain researcher in Toronto, told me that you cannot make change unless you publish. So I had to take the challenge. I put out a UBC Flex project, and brilliant Andrew Jamroz became a forensic auditor of my charts. He looked at every detail to make sure we truly met all the criteria. He saw CRPS patients, and over a year he was able to extrapolate my chart with the help of Mike Berger, MD, PhD, who was my former resident. Brilliant researcher. We were able to do this. We found 39 patients at just under 3 months average referral. This is a large study for CRPS. And what was wonderful, we had 1 patient who was at almost 1 year who didn't respond, but the other half had complete pain resolution, and the remaining half, even though some of them had some pain and stiffness, they were able to go on to full function, work, look after their kids, play tennis, play an instrument. But you cannot rest on your laurels, and you cannot be overconfident. So this patient actually had a crush injury, not CRPS, based on the criteria. This woman was sent to me by neurology. She had CRPS for sure. But her toes were not stiff, they were weak. She couldn't extend them. So I put through that ball of fluid my nerves study equipment, and I could hear the characteristic sign of nerve damage. This was CRPS type 2, and my spidey sense went wild and I panicked. I got an urgent angiogram, which unfortunately took 2 weeks. Prednisone took away her swelling, and she actually had some pulses in her feet, but there was no blood flow consistently below the leg, and the surgeon was able to rescue her leg. Now, I knew this because I had previously seen a woman referred to me by neurosurgery with back pain, sciatica, CRPS type 2, that also responded well to prednisone. But when we went to examine her pelvis and back on imaging, the radiologist called me in a panic saying he'd never seen such blockages of blood vessels in a patient. And she was young. She had been infarcting her kidneys. She had infarcted her nerve in her leg. She had vascular surgery, even though she had pulses in her foot. But unfortunately, the disease was so bad, she had to have an amputation. I had no way to describe this. There was no reason that you could have such bad vascular disease without signs of vascular ischemia. I asked everyone I knew. I read as much as I could, and nobody could describe it, until Dr. Christine Chapman from UBC suggested look up ischemic monomelic neuropathy, and there it was, described decades ago at the Mayo Clinic. Now, Danica was my student, and she took on the task. Now, we did find it in the vascular surgery after bypass surgeries, but no one had really talked about it since the Mayo Clinic 40 years ago, that it could happen in patients without surgery. Just before we published, Internal Medicine sent me a patient for numbness and weakness in the foot. A man who had previously had swollen knees and ankles, presumed gout, responded to prednisone. Exact same presentation. EMG went in, nerve damage to the foot. Vascular studies showed aneurysms behind both knees, no blood flow to one of the vessels in his foot. He did very well with surgery. No patient can ever come to me again this way, too late. So we got a grant from Facilities Engagement through Doctors of BC, chosen locally, and we put together a triage protocol. Andrew Jamroz was extremely helpful in putting together the literature. We got the word out. I want every patient on the island seen by me quickly. We still need more evidence. So I bought this little contractor's camera for my phone that you would check for heat in your house. And suddenly there it was. You could see hot and cold on your screen in front of you in real time. And with prednisone, they were getting better. Patients were shocked to see their improvements. We joined together in telling our stories. As they got better, they could see and feel and prove it. Now, Emily Krause is an incredible nerve surgeon, my good friend, and she has changed everything I do in rehab through her amazing nerve surgery that is just so cutting edge. So when I saw this man, he had ruptured his biceps tendon here and injured the median nerve. He responded very well to prednisone in terms of range of motion and swelling, but he said his pain was unlivable in this part of his arm. So in desperation, I grabbed my ultrasound machine, found the nerve just before the surgical site, and I injected lidocaine to freeze it. The hand went to a burst of heat. You can see it went up 7 degrees in that median nerve area. And he looked at me and said, I have no pain. What have you done to me? So I quickly called Dr. Krause, and she was able to go in, and the nerve was severely damaged when the tendon ruptured it. She was able to reconstruct it successfully, and he had a great outcome. And then shortly later, a woman who had had a shoulder replacement developed ulnar neuropathy. Prednisone really helped the CRPS, but the pain was still there mercilessly, and she was able to relieve that pain. I got another medical student, Sarup, went to the literature, and lo and behold, she found people had used this little device in medicine, and we were able to publish 4 cases. So now every patient gets a visual story from me now. We photograph their images, we take a heat map. This man was so afraid he had actually never taken a step since he fractured his ankle. He comes in each week, and I do a nerve block to the sensation of his leg so he can convince himself that it's safe to walk, and he's getting better. Because of COVID, we had to cancel electives. I asked Maddie if we could do a description of a patient over time and make a video to try to publish it. So we're doing that now. This man had a neck fracture and he had a spinal injury, but Dr. Krause and I realized it was actually nerve damage in his arm that was causing weakness, not a spinal injury. So we tracked him in clinic, and at 2.5 months, he presented with CRPS. All the classic features: temperature, shiny skin, lack of range of motion, and multiple joints. So we put him on prednisone, and a week later, look at him. He is able to move his fingers. He's able to start reaching his arm overhead as well. He was getting better and better, and he's describing here how much happier he is after 1 week. And within 2 months, he's doing great. So now we are in the time of COVID, and we are seeing patients virtually unexpectedly, and I saw a huge number of patients because people still fracture. I had to rely on the referring surgeon's reports because they couldn't go to hand therapy, and I've had 2 students doing a quality assurance for me to make sure we did the safe and right thing. Now, thankfully, Spidey Sense still works in lockdown, and one of the first patients I saw, her story was completely wrong. It made no sense, the way she was moving, the way she was speaking, and she was booked urgently the first day clinic opened. You see, she was falling by this point, and she had a massive brain tumor in her brain that was causing this dysfunction. Thankfully, we got an urgent MRI in a couple of days, and Dr. Henschel was able to remove this tumor, and she's had a full functional recovery. So here's my course of prednisone. It's $27 for 4 to 6 weeks. Now, I want you to know that hand therapy is absolutely crucial and necessary, but MSP and Island Health do not help my patients pay for it. They have to do it on their own, and it's very costly, and we do need help. So thankfully, there's Dawn Waterhouse with Island Health Research. Dawn has made my life so much better. We have no nursing, no therapist, no funding of any kind. I have to constantly look for grants, industry grants, and Dawn makes it happen. She finds me grants, she finds me people. We are putting in initiatives. I'm building my own research team for my own money to serve my patients, to make their stories heard. So thank you so much to Dawn. And Annie Moore, I couldn't do it without your lovely descriptions and support of our clinic. So thank you so much for letting me tell my story today. I hope you enjoyed the format.